I'm going to be talking to you today about the stabilisation and preparation of the patient prior to transfer. Now, the thing about preparation is it's absolutely key. It's the thing that will determine the success of your transfer. And preparation needs to start a long time before you actually meet the patient. You need to have all the right equipment, you need to have all the right training, you need to have all the right personnel. Now, the way you go about that will depend on where you are, but it may involve going on courses, training up your individual people, and making sure that you have adequate protocols in place. What you'll find is the difference between a successful transfer and the occurrence of incidents is all about your preparation. Now, a really key principle when it comes to the transfer is that it doesn't matter how far you're taking the patient, be it 100 yards or 100 miles, you need to go through exactly the same process. Now, the reason is that it doesn't matter how far you're going, exactly the same problems can crop up, and the result can be exactly the same issues for the patient. One of the key decisions you're going to need to make early on in your pre-transfer preparations is whether you're going to stay and spend potentially a prolonged period of time getting the patient absolutely as stable as possible prior to the transfer, or whether you're going to get them out of your hospital and to the place of definitive treatment as fast as possible. And this is commonly known as the stay and play or scoop and run conundrum. Now, actually that decision is usually a pretty easy one, and it depends upon where the risk-benefit analysis lies for your patient. For example, if you have a patient present to your district general hospital following a multi-vehicle accident and they've sustained a polytrauma, then the best thing to do is to transfer them as fast as possible so that they can have their definitive treatment. However, if you have a septic patient who's ostensibly going to receive the same treatment that you're already administering when they get to their next hospital, then you should stay and make them as stable as possible prior to that transfer. The North West London Critical Care Network has an algorithm which contains a mnemonic running from A for airway through to Q for quality assurance, which covers all these areas. You don't need to use this mnemonic, but you do need to have something which is clear, structured, and thought out in advance. Now, the whole point of structuring your preparation and stabilisation is to avoid unnecessary interventions during the transfer. So, for example, you don't want to find yourself doing an intubation in the back of an ambulance which is travelling at 60 miles an hour and shaking from side to side. But there may be things that happen that you can't plan for, but you need to be aware of the possibility. Now, the example for that would be the neurological patient who, when transferred, suddenly develops a blown pupil. And you do just need to think about what would you do in that circumstance were it to occur. Or with our septic patient, if they suddenly drop their blood pressure and there seems to be a problem with a noradrenaline infusion, how are we going to get around that? So this is all about anticipation on top of the preparation that we've already made. Even after the best planned transfer, things will happen which you were not anticipating. However, if you've gone through the checklist, if you're adequately trained, and if you've got the right equipment, you'll be in the best possible position to deal with those incidents.